Hello to everybody. Thanks very much for having me, and thank you for your patience. I mean, I'm well aware that me and other people are standing between you and lunch. So I'll try to be short. I was asked to talk about economic considerations concerning giving access to healthcare to refugees and other vulnerable migrant populations. And I very much like the title. I didn't invent the title. Actually, the organizers gave me this title, and I like it very much. What are the economic benefits of financing refugee and migrant health? Because very often discussions are about, well, what is the economic burden of giving benefits, of giving my health to migrants and refugees. And you may recall this shift in policies, for example, for Spain, when there was an economic argument behind the fact that with this royal decree in 2012, they shifted the universal access system to highly limited access, especially for undocumented migrants, with the economic argument we can't afford decent health care for everybody due to the economic crisis. What I will talk about today is I will try to give you an insight into a thematic study on cost analysis of healthcare provision for migrants and ethnic minorities that was done in 2014 and 2015. This study was part of the EcoHealth study commissioned by IOM, the Migration Health Division from the regional office in Brussels, and which was co-funded by DG Santé. And what we did in this study, we did a kind of analysis and comparison of costs of healthcare provision in 4 European countries, and I will show you the 4 countries just in a second. Our target group were migrants in an irregular situation, so migrants who do not have or have just very limited access to health care. We were aiming at developing an innovative methodology. We used primary data to construct vignettes for healthcare settings, and we were comparing costs of primary care, what we defined as timely treatment. So when you have an early onset of a disease, you get timely treatment in a primary care setting. We compared this to hospital care, which we framed as delayed treatment, so a kind of more severe condition you get into if you don't get timely treatment in a primary care setting. So these were the principles, this was the principal layout of the study. The countries involved were 4. It was Austria, it was Belgium, Italy, and Spain. And here you have a rough overview of the main features of these countries. Population dates are from 2013, so it will be a little bit higher up now, but it will be basically more or less the same. This is the legal total population. And you also have estimates concerning irregular migrants. It's a minimum and maximum estimation for 2008. And I do apologize, there is no more recent data than 2008. You may remember that in 2008 there was this big European study, Clandestino, Counting the Uncountable. And they so far were the only who tried to come to reliable estimates on numbers of irregular migrants. What we know from many other sources is that it is very much likely that the numbers of irregular migrants residing in several countries in Europe did rise, of course, with the influx, with the recent influx of refugees, but there is no official data on stock of irregular migrants or flows of irregular migrants in the EU. The healthcare financing systems of these countries were for 2 countries insurance-based, for 2 countries tax-based. And what you have here in the bottom concerning regulations on access to healthcare for irregular migrants, this is information from a European project called Healthcare in Nowhere Land or Now Here Land that was investigating the legal frameworks for healthcare, access to healthcare for undocumented migrants. And you can see that Austria, which is a very rich country, nevertheless, in Austria, there is a regulation on no access for irregular migrants. The only thing that you can get on a legal basis as an irregular migrant in Austria is emergency care, because as in every other European member state, you cannot deny emergency to nobody. So this is the only regulation that also covers irregular migrants in Austria. The case is different in Belgium and Italy. Those are two countries who provide specific access to specific services for irregular migrants under specific conditions. And Spain, as I mentioned it already, in 2010, when we did this study, there was full access also for irregular migrants to healthcare services concerning the legal frameworks. I'm not talking about practices here, I'm talking about the legal frameworks. But this changed for the worse along with the economic crisis. So these 4 countries were involved in the study. The project partner were the IOM, as I said before, the Center for Health and Migration, which is a private research institute based in Vienna in Austria. We had an international advisory committee, and we had, for the 4 countries, we had implementation partners who supported us in the implementation, and we had practice partners, a hospital and a primary care setting, who provided us with the data and supported the data collection. You can see one room missing here, and that is Belgium. In Belgium, we tried hard, but we didn't find a hospital that could support us with data, so we had to rely on our partner Médecins du Monde, who provided us with data from their polyclinic in Brussels. Economic analysis with vignettes. How is that done? What is a vignette, you may ask? Vignettes are short descriptions of scenarios comprising defined core elements. And these core elements can be varied systematically to illustrate different hypothetical cases. Such vignettes, they are based on primary data, and they are supplemented further with register data, with desk research and expert opinion. And with these variable sources, they provide a quite robust economic result, and they are more generalizable than single case studies. So when you look at the vignette, and this is a little bit confusing, you're not looking at a single case. You're looking at the hypothetical case that is more standardizable than a single case. What we did, we used predefined selection criteria, and from these criteria, cases were selected from random samples collected from each healthcare provider who participated in the study. And from this real-life data, we constructed real-life vignettes. And these real-life vignettes then served as a basis for development of a comparison vignette, where we had the comparison then to the respective other healthcare setting. You remember, primary care setting on one hand, hospital care setting on the other. You have here a graph which demonstrates the case selection for the vignette. So you have lots of patients. For the Austrian hospital side, for example, we had a sample of about 250 patients who were irregular migrants and had been given treatment in a defined period of time. And from these patients, there was a random sampling to have 10 cases, and from these 10 cases, then there was a selection made by experts along criteria of representativity for patients, variety of diagnosis between countries and setting, and the diagnosis had to be one that is sensitive to primary care conditions, so that can be treated in primary care and will have an impact when treated in primary care. So this was then the case for the vignette. And you have here a maybe even more confusing graph that shows you all the data that is fed into such a vignette. This is the example for Belgium. You see all kinds of pharmaceutical price information service, national fee catalogs for outpatient practitioners, Eurostat database, to be able to very pinpoint the economic costs within this vignette. So the internal validity of the economic analysis in this format is very, very high. The data that was collected was, first of all, of course, health problems and the treatments that the patient received. That was about the diagnosis, the therapy, also the facilitating services, for example, mediators or interpreting services. And along with this, all the related costs were calculated. And we also collected, where possible, this was not always possible, the wider determinants of health. So we were looking at what are the living conditions of people. do they work? Do they have an income? Do they have to support, for example, relatives? And it was very interesting for us as well to see the positive economic contributions of irregular migrants in Europe are considerable. I cannot go into this detail right now, but you may find it interesting that all of the people that were covered in those vignettes, they were working, they were supporting family members in their home country, and also members of the community or family members in the country where they were residing at the moment. So they were working on the black labor market. They were contributing to economy. The diagnoses that were selected for vignettes were asthma, coronary heart disease, depression, diabetes, and epilepsy. We also worked around tuberculosis because we had some cases of tuberculosis in the sample, but had to postpone that for hopefully a next study, because infectious diseases are something that cannot fit into the vignette approach as it is right now, but we are working on that. And the economic analysis that was done on 3 types of costs. We were looking at direct medical costs, that is medication, diagnosis, and the time of the health professionals. We were looking at direct non-medical costs, that is the time of the patient, the travel of the patient, the time at the healthcare provider, and the travel costs. And we were looking at indirect costs, and that is loss of income or loss of productivity. And we had 3 perspectives to look at these costs. The patients, what kind of costs are arriving for the patients, what are the costs for the healthcare system, and what are the costs for society from a societal perspective. These are 2 examples of 2 vignettes, and I have some infographics with me if you're interested in looking into that with more time than we have now here together. The first one you see, that was a vignette where the real-life case came from a hospital. It was in Spain. It was a person, a male from Pakistan. He was 46 years old, working on the black labor market and having a shared private accommodation for which he paid a fortune. He was diagnosed with coronary heart disease, and he was, as an emergency case, immediately put to hospital, where he did get a bypass operation, and that amounted 19,000 euros for costs. And we designed the vignette, what would have happened if this person would have given treatment in a primary care before he developed this really severe condition, and here the cost would have been 90 euros from the perspective of the healthcare costs. So you see already this is quite a considerable difference. The second case is the other way around, where the real-life vignette, the real-life case was drawn from a primary care setting. This is a case from Austria. And it may be interesting to notice that this case, and remember it is random sampling, this case was a female, a lady from Hungary, 50 years old, and you may say, well, Hungary, it's a European country, a member state, but still it is possible to be an irregular migrant being stranded somewhere, even if you are a European citizen. So we decided to keep this person in the sample because she was within the sampling criteria. And she was treated in a primary care setting in an NGO, which she first approached with a broken ankle, a swollen ankle. And then it turned out that she was suffering from depression. And her first approach to this NGO was with physical conditions, because she wanted to somehow test this out. How reliable are these people? And once, when she had the trust, okay, these people are okay and they will not cheat me and they will treat me right, then she reported symptoms of a mild depression. With this mild depression, with the treatment of this mild depression, that amounted 230 euros in total. And we constructed a vignette. What would happen if this was not dealt with in primary care? What if this mild depression turns into a more severe, not really severe, but a little bit more severe depression, where admission to hospital would be necessary, and there the costs would amount 3,810 euros in total numbers. So again, this is quite a considerable difference. So looking at the overall results, what we can say with this economic study, using this vignette approach, we can say that potential cost savings of timely treatment in a primary care setting amount at least 49% and up to 100% of costs that would occur in a hospital setting for treatment of more severe medical conditions. Yeah, and I think this is more or less my last sentence. What we produced here is a kind of infograph which should work as an appetizer for people to look into these economic considerations, and I have some with me if you're interested. We are now working on the question, how can we make this piece of evidence also relevant for policymakers? And I would be very, very happy to learn from you how we could possibly do this. One step that we did is we made for the different countries policy briefs. This is the one for Austria. We also have it for Belgium, Italy, and Spain to support us in the dissemination of the evidence that we created here. Thank you very much.
Thanks a lot, Ursula, for this very interesting presentation. Is there any question from the, Hamish?
I think policymakers are indeed very sensitive to numbers and savings, but I think these findings, they do not differ from regular recommendations. Early detection is very important, early treatment is very important. In what way were your conclusions different from what you would recommend to the regular native population? So how is it specific to migrant populations or refugee populations?
You're perfectly right. I mean, that primary care is more cost-saving compared to hospital care is already written down in the Alma Ata, and that dates from the 70s, no? So that's nothing new. I think the new thing is that really there are hard numbers that you can rely on. And your question, what is the difference between these concerning refugees or vulnerable populations? I think the main difference is that irregular migrants are really on a legal basis excluded from primary care in most of the countries. And this is a ridiculous legal framework, because it really it opens up a gateway into healthcare provision where it's the most expensive one, that is emergency. Maybe that's the one difference to an average population.
Yeah, so the key recommendation would be actually opening up primary care to refugee populations, which saves a lot of money. Yeah.
Thanks. We have another question here in the back.
Okay, thank you for your presentation, Ursula. I was wondering if you plan to go more in deep in regard of the contribution of the workforces coming from the migrants and refugees while they stay longer in a country in terms of contribution to the general security budget, let's say, or through the taxes or whatever. Do you plan to include such kind of comparison between countries?
We would love to, because I think that the contributions are considerably high. And a few years ago, I think there was a shift that allows European member states to add what is produced by the productivity of the black labor market is part of their budgets. So in official numbers, contributions of the black labor market are acknowledged already. So we would love to do that. But I mean, the question is, where could we get the funding from? So if you have an idea, just let me know.